In this video, we will talk about acute pulmonary embolism, or PE. Acute PE is a common and potentially life-threatening medical condition characterized by sudden blockage of the pulmonary artery or one of its branches by emboli originating from elsewhere in the body. These emboli most often arise from pre-existing venous thrombosis, which will be the focus of this video, but can also be caused by other material entering the venous system, such as air or fat. Because of the shared pathogenesis, the risk factors for PE reflect those of venous thromboembolism. These factors influence portions of Virchow's triad, which describes the three components that increase the risk of venous clot formation. Let's quickly go over each component and some example risk factors. First, there is endothelial injury, which promotes thrombosis by converting the normally antithrombogenic endothelium to a prothrombotic state. Second is venous stasis, as obstruction or slowing of venous blood flow facilitates growth and propagation of microthrombi. The third component is blood hypercoagulability, which refers to an altered balance between coagulation and fibrinolysis that favors clot formation over dissolution. Many risk factors affect multiple components, contributing to the risk of thrombosis. Most pulmonary emboli arise from thrombosis that develops in the deep veins of the lower extremities and pelvis, which have increased blood stasis due to the effects of gravity. The deep veins are also surrounded by musculature that can promote dislodgement or fragmentation of thrombi during forceful contraction. Emboli arising from lower extremity vessels can ascend within the inferior vena cava to reach the right heart, where they are then pumped into the pulmonary artery. Large emboli can lodge at the bifurcation of the main pulmonary artery or within the lobar branches, while smaller emboli typically occlude distal vessels at the lung periphery. Because the lungs are supplied by a dual circulation from both the pulmonary arteries and bronchial arteries, pulmonary infarction is relatively uncommon. Smaller emboli are more likely to cause infarction as they occlude more distal vessels that are poorly connected to the bronchial anastomoses. Pulmonary infarcts are typically wedge-shaped due to the triangular perfusion field of small arteries at the lung periphery. They are typically hemorrhagic and red-appearing due to the dual blood supply and low density of lung tissue, which allow blood seepage into the infarcted territory. PE can have a significant effect on gas exchange and hemodynamics depending on the size of the obstructed region. The most common blood gas abnormality is hypoxemia, which is primarily caused by increased ventilation perfusion mismatch or VQ mismatch. Obstruction of the pulmonary arterial vessels by an embolus causes alveoli in the affected region to be ventilated but not perfused. This increases the amount of dead space, the volume of inspired air that does not participate in gas exchange, which results in an abnormally high VQ ratio within the regions directly affected by the embolic obstruction, leading to wasted ventilation. At the same time, there is redistribution of blood flow away from the affected pulmonary segments toward the remainder of the lung. Inflammation of poorly perfused lung tissue also results in surfactant dysfunction and atelectasis. These processes together create areas of abnormally low VQ ratio within areas of the lung not directly impacted by the embolic obstruction. These low VQ regions are the primary cause of the hypoxemia, as hemoglobin traveling through pulmonary capillaries in these regions will not become sufficiently oxygenated. Another factor contributing to the blood gas abnormalities is an increase in the central respiratory drive caused by hypoxemia and pulmonary inflammation. The resulting hyperventilation does not significantly improve arterial oxygenation because hemoglobin is already almost fully saturated with O2 in lung regions with normal VQ. Although increased ventilation creates areas of higher VQ, The blood traversing these regions is unable to take up extra oxygen to compensate for the deoxygenated blood returning from low VQ regions. In contrast, the CO2 dissolved in venous blood is normally only partially removed as it passes through the pulmonary capillaries. Increased alveolar ventilation in high VQ regions can compensate for low VQ regions by allowing exhalation of additional CO2. In fact, the hyperventilatory response frequently leads to excess CO2 removal, and many patients with PE present with hypocapnia and respiratory alkalosis in addition to hypoxemia. One important exception is that a massive pulmonary embolism can increase dead space so much that the total alveolar ventilation remains relatively low despite the increased respiratory drive. This allows CO2 to build up in the blood, causing hypercapnia instead of hypocapnia. The gas exchange abnormalities occurring with PE are reflected in the arterial blood gases, which commonly show hypoxemia, a widened alveolar arterial oxygen gradient, and hypocapnia with respiratory alkalosis, although, as mentioned, patients with large PEs may instead have hypercapnia. Massive pulmonary embolism can also result in hemodynamic complications. Blockage of a significant portion of the pulmonary vascular bed leads to an increase in pulmonary vascular resistance, with subsequent pulmonary hypertension and increased right ventricular afterload. This can manifest with right ventricle dilation and, in severe cases, right ventricular failure. When the right ventricle is unable to maintain sufficient pressure to force enough blood through the obstructed pulmonary circulation, the decrease in left ventricular preload reduces cardiac output, causing hypotension and potential circulatory collapse. Although the size of the embolism often corresponds with symptom severity, the clinical manifestations of pulmonary embolism can be highly variable, ranging from no symptoms to obstructive shock and sudden death. When symptoms are present, the most common are dyspnea due to the impairments in gas exchange and pleuritic chest pain, especially with smaller, more peripheral emboli that cause pleural irritation. Cough occurs somewhat less frequently and may be associated with hemoptysis, particularly when there is underlying hemorrhagic infarction. Other important clues include symptoms suggestive of deep venous thrombosis, such as lower extremity swelling, erythema, and tenderness. Physical examination findings include tachypnea and tachycardia. Hypotension is less commonly seen and is typically indicative of a massive PE. Findings associated with pulmonary hypertension and right heart strain may also be present, such as accentuation of the pulmonic component of the second heart sound and jugular venous distension. The diagnosis of PE can be complex and progress stepwise through a variety of laboratory and imaging studies. Patients are often initially stratified into different risk categories by a clinical scoring system to determine the pretest probability of disease. Some patients undergo laboratory testing for fibrin degradation products, such as the D-dimer. These byproducts of fibrinolysis are typically elevated in the presence of recent thrombosis. A negative test can be useful for ruling out PE in patients at relatively low risk, but the test is less useful in high-risk patients due to the potential for false negatives. Patients at high risk for PE and those with positive D-dimer test results frequently undergo further evaluation with advanced imaging studies, such as CT pulmonary angiography or ventilation perfusion scanning. CT pulmonary angiography is typically the imaging modality of choice. It utilizes intravenous contrast to enhance blood flowing through the pulmonary arteries. Thromboembolism causes filling defects to appear, which are areas within the arterial lumen that do not undergo contrast enhancement. When CT angiography is inconclusive or contraindicated, VQ scanning is frequently used as an alternative imaging exam. VQ scans use an inhaled radiotracer to visualize the ventilated regions of the lung, followed by an intravenous radiotracer distributed throughout the pulmonary vasculature. Patients with PE will have preserved ventilation, but one or more perfusion defects corresponding to the regions where emboli obstruct blood flow. Because PE has a variable clinical presentation and can sometimes be rapidly fatal if left untreated, it is imperative that treatment be administered as soon as possible. The mainstay of treatment involves anticoagulation therapy to prevent further clot propagation, often with agents such as heparin and factor Xa inhibitors. More aggressive strategies are important in hemodynamically unstable patients and include thrombolytic therapy with agents such as tissue plasminogen activator that actively work to dissolve clots. Embolectomy can also be performed to physically remove the clot. The duration of anticoagulation is variable. Many patients continue anticoagulation for months and sometimes indefinitely, depending upon the presence of provoking events and specific risk factors such as ongoing malignancy. Because PE can be life-threatening, thromboprophylaxis to prevent deep venous thrombosis is an important part of medical management of high-risk patients. Preventive measures include injections of low molecular weight heparin or mechanical methods such as intermittent pneumatic compression or graduated compression stockings. In summary, acute pulmonary embolism is a common and potentially life-threatening medical condition, characterized by sudden blockage of the pulmonary arteries by emboli that usually arise from lower extremity deep venous thrombosis. The risk factors for pulmonary embolism reflect those of venous thromboembolism and include prolonged immobilization, recent trauma or surgery, conditions such as malignancy or pregnancy, hypercoagulability disorders, and tobacco smoking. The clinical manifestations of pulmonary embolism can be highly variable. The most common presentation is dyspnea, along with pleuritic chest pain. Tachypnea and tachycardia are also frequently seen, and cough and hemoptysis may be present. Other important findings suggestive of PE include signs of deep venous thrombosis. Massive pulmonary embolism can also present with hemodynamic complications, including pulmonary hypertension and obstructive shock. Arterial blood gases commonly show hypoxemia, a widened alveolar arterial oxygen gradient, and hypocapnia, although patients with large PEs may have hypercapnia instead. More specific diagnostic tests include laboratory analysis for fibrin degradation products, such as the D-dimer, and advanced imaging studies such as CT pulmonary angiography or ventilation perfusion scanning. The mainstay of treatment involves anticoagulation therapy to prevent further clot propagation. Thromboprophylaxis with heparin or mechanical compression is also an important part of medical management of high-risk patients.